Welcome back to our whiteboard learning channel, MLSQR, Medical Lab Science Quick Review. Do you know how to identify immature white blood cells? Part 2. And what other cells might appear similar? This has been a perennial challenge in clinical hematology when patient care is at stake. Why is sharpening our hematology morphology skills important for patient care? In our previous video, part 1, we learned about immature myelogenous cells, with emphasis on the promyelocyte. Hematopoiesis that we will be referring to, but not in any detail, includes myelopoiesis, lymphopoiesis, monopoiesis, erythropoiesis. Blasts possess certain identifiable characteristics, but they are also present in many different sizes, shapes, colors, and forms. What do we see here? Note the broad spectrum of immature myelogenous cells from blasts to eggs. If we see for the first time in a patient rare blasts, a few promyelos, and many myelocytes and metamyelocytes, what do we and the pathologist suspect? Chronic myelogenous leukemia, perhaps myelodysplastic syndrome. Another characteristic of CML is basophilia, greater than 5%. Further studies will definitely be helpful with cytogenetic testing finding Philadelphia chromosome translocation 922 and molecular testing finding chimeric fusion oncogene BCR ABL1. Back to our topic, what do we see here? Myeloblasts are 14 to 18 microns in diameter with a high nuclear cytoplasmic ratio up to 8 to 1, seen with a large oval blue-violet nucleus with a fine chromatin pattern possessing 2 to 4 nucleoli. We see a thin rim of blue cytoplasm, some with a few primary azuric granules. And here we see our rods. Our rods are large azurophilic crystalline cytoplasmic inclusions seen in blast cells in acute myeloid and promyelocytic leukemias and myelodysplastic syndrome. They are fused lysosomes rich in lysosomal enzymes seen in the primary azurophilic granules. Identify. As you may have seen in my last video, promyelocytes may be actually larger than myeloblasts, 16 to 25 microns in diameter. Promyelos have more condensation of the chromatin pattern and more azurophilic cytoplasm with more azurophilic granules. You might see a cytoplasmic paranuclear halo. For your information only, high promyelocyte percent in our manual diff may be suspicious for AML not otherwise specified, AML without maturation, acute promyelomonocytic leukemia, and myelodysplastic syndrome. Please note, acute promyelocytic leukemias have a high risk of disseminated intravascular coagulation because when promyelos release their primary eosinophilic granules, they have a procoagulant effect, setting off DIC, which is life-threatening. Relatively small myeloblasts are often missed because they look like a normal lymphocyte in many ways. They both look similar because they are both round mononuclear cells with a thin rim of blue cytoplasm. But wait, smaller myeloblasts are distinct because they have a finer chromatin pattern, not dense and blocky like a lymphocyte. Plus, look for cytoplasmic granules in myeloblasts. They are not present in mature limbs. Here's the bone marrow of a patient with acute lymphoblastic leukemia. Can you tell and describe the difference between a myeloblast and a lymphoblast? They both have a scanty rim of blue cytoplasm and nucleoli. Again, note the fine chromatin pattern of the myeloblast and the blocky, dense chromatin pattern of the lymphoblast. Again, note the cytoplasmic granules seen in the myeloblast. You might also see our rods in the myeloblast. What do you see here? I hope you're right, atypical lymphocytes. Please see my other video about infectious mono and the Epstein-Barr virus. Look for leukocytosis, lymphocytosis, atypical lymphs, and expect a positive mono test. What do we see here? Another peripheral blood smear from a different patient. Nucleate RBCs are easily identifiable and distinct from blasts by looking at their homogeneous cytoplasm, which appears as polychromasia, slightly more basophilic than that of a mature red blood cell. Their nucleus appears dense and blocky like a mature lymphocyte. Here we see two patients with bone marrow stress to produce more red blood cells in response to hypoxia and anemia with erythropoietin. Evidence of this is seen as nucleate RBCs and polychromasia. The first example is one of sickle cell anemia, demonstrating orthochromatic normoblasts with slightly more basophilic cytoplasm as a mature red blood cell, giving away its cellular lineage. The second is a baby with hemolytic disease of the newborn, most likely due to a bioincompatibility between mother and baby with fetal maternal hemorrhaging and mixing of blood. Polychromatophilic normoblasts are slightly larger with more basophilic slate blue gray cytoplasm because it is more immature. If you stain a few drops of the EDTA lavender top specimen with a supravital stain such as new methylene blue, polychromatophilic red blood cells would appear as reticulocytes showing its ribosomes. Normal or abnormal? Normal monocytes appear large, 15 to 20 microns in diameter, with a folded nucleus that may appear rounded or indented like a band or meta, but with a looser, lacy chromatin pattern and a blue-gray ground glass cytoplasm that may show vacuoles. As you can see, they can be confused with atypical lymphs and immature myelogenous cells. Compare and contrast normal monocytes with monoblasts and immature monocytes. Can you identify? Promyelocytes are large with a slightly indented folded nucleus with a delicate chromatin pattern with one or more nucleoli present. The light blue cytoplasm has scattered azurophilic granules. This is for your information only because we don't identify monoblasts, just blasts. You can call them immature monocytes. Why do we need to know how to accurately identify abnormal cells in the peripheral blood smear exam? Let's take it into perspective that we play an important role in the healthcare team. Foremost, a key action item is to call critical values. Patient care is at stake. Another key role is when a patient comes to the emergency room, urgent care, or primary care visit with or without symptoms. If we see suspicious immature white blood cells, suspicious for blasts, and there is no previous diagnosis of a leukemia or lymphoma, then we initiate a path review. And the likely scenario is that the pathologist will discuss findings with recommendations to the primary care provider to consult a hematology oncology specialist for a bone marrow exam with cytochemical stains, biopsy, and further bone marrow testing. Flow cytometry. cytogenetics, including follicular in situ hybridization and molecular testing. Thank you for your time, attention, likes, and subscribing. I hope that this video was helpful as we learned about some abnormal cells in the CBC peripheral blood smear exam and how we play an important role in healthcare team for patient care. Learn more details in MLSQR. I hope to see you in my next video.